Um, I'm Andrea Picula. I'm from Southern California, and my co-moderator for this session.
Leandro Totti Cavazola from Brazil.
We're really excited to be here and obviously want to thank Flavio and the program committee for inviting us. We're even more so excited about this session because it's one of the first that we have had some live cadaveric dissections for a few procedures that we're going to be able to see that'll be transmitted here into the room from the lab. So we'll get to see a few very good techniques from obviously some of the people that you've already heard speak today. But first, we are going to start with Professor Gandhi, who is an experienced general and laparoscopic surgeon, specializing in a variety of laparoscopic inguinal as well as ventral hernia repairs and large complex ventral hernia repairs, both open and endoscopic TAR techniques. He serves on a variety of different society committees, including the Association of Minimal Access Surgeons of India, as well as the Indian Association of Gastrointestinal Endosurgeons. And he is the editor of the hernia section of a journal focused on minimal access surgery. So we'd like to welcome you. He's going to speak to us on cadaver training, logistics, and future.
Thank you, Andrea and chairpersons, and thank you very much here. Good afternoon to all of you. So I have no disclosures related to this particular talk. I bring you greetings from my institution, the King Edward Memorial Hospital in Mumbai, where we perform most of our cadaver workshops. So if I take you back in the history, around 15th century is when Andreas Vesalius demonstrated the cadaveric dissection in Padua, and after that there was a lot of interest generated. There were hospitals which were trying to conduct different kind of cadaver workshops in different organ training. This is what hit the headlines. This 87-year-old lady who donated her body, and she had multiple comorbid problems for which she was admitted to the hospital. And ultimately, this is where she had donated her body, and it was cut into 27,000 pieces. And this was one of the first landmark in the history where this has now become a project for the Visible Human Project, because they could slice it and see it under the cameras. And then this is a model on which today the modern cadaver system has come into existence. So how does one start the program? You always start off with a team building process, and I was very lucky to have these members with me who were my co-AWR surgeons from India, and they helped me make a model of how to go about, because without a team you cannot go ahead and make a successful cadaver program. And this is where we are in action during the live cadaver workshops, where we exchange our knowledge and decide how we have to set up things. How does one source a cadaver? In our country, we have cadaver sources from two sources. One is from the anatomy, where you have the voluntary donation by the families, and it goes through a particular protocol which you have to follow. And the second one comes through the forensic departments, which are unclaimed bodies, and they have to follow certain legal procedures before they are coming up for the cadaver dissection program. Guidelines, when I was preparing for this talk, I went to the literature, and today the Japanese society is the only one which has got a big paper which talks about the guidelines in terms of the cadaver dissection, and they go through all the models about what's had to be done about the procurement, the legal aspects, the training, and the cost issues. And if you see the details in the paper, they have really highlighted most of the smallest possible things which are required for a cadaver dissection. What we did back home with our AWR community was to prepare this manual. And this is the first ever manual in the country of ours in India, where we have given details about the cadaver sourcing, the cadaver storage, cadaver training protocols, how to go about doing a laparoscopic and open procedures, and also about how one takes evaluation feedback and the certification process. This was formally launched in our hospital subsequently. So if you look at cadaver preservation today, there are a lot of papers which will be talking about different ways to do it. So you have a formaldehyde treated cadavers, but the problem with them is the health hazards. And we as AWR surgeons, what happens is the planes become very sticky. So formalin sometimes gets very, very tricky if you want to start a cadaver program as far as the abdominal wall is concerned. The second is the thigh limb up cadavers. What it does, it preserves the colors. So when you're doing the cadaver dissection, it becomes near natural when you're using a thigh embal, but it has to be handled in a proper way, in a protocoled way. Otherwise, again, you can have very sticky planes and there could be a problem. Third is a very cheap method, which is known as a saturated salt solution. It is cheaper, but commercially it is very difficult to kind of, go into different centers and use this particular technique because it needs a lot of learning curve. And this is the one which has been our workhorse, the fresh frozen cadaver system. So for this, the best part of it is that it comes with the excellent texture. And I'll just show you what exactly we do when we use a fresh frozen cadaver, because anyone who wants to learn cadaver in an abdominal wall, this is the best model. So you need a storage system which stores a cadaver. Initially, they are immediately, as soon as we get the donation or the unclaimed bodies, they're kept at minus 20 degrees centigrade. And 1 week before the workshop, you have to get them out at around 4 degrees. And 24 hours prior, you have to get them to room temperature. I have practically been and used all the types of cadavers across the world. I've been to different centers, but this particular model is the best one if you want to really try and start off it. And they're not very expensive stuff to buy for. The next thing after you have procured, you need a lab. So this is one of the centers where we are going to have it in Chennai, our meeting, where we have a bioskills lab, where we have the cadaver training program. But in Mumbai, where we are at King Edward Memorial, this is the first dedicated cadaver OT. We have actually made a class OT where we have got all the facilities available, and we've got 2 tables as of now, which we're going to expand subsequently, but it has got all the facilities of performing a modern operation. And this is where we train ourselves into cadaver training for the students. Once we have done that, whenever we announce a program, this is the way we go ahead. We announce a program well in advance. We've got the calendar for the full year, and we have the program schedule about what's going to happen. When the candidates come for the program, we always do a pre and post test. And this is something which I've learned from my European Hernia Society team. So what happens is that you understand how much a surgeon has really got the knowledge about the cadavers during this course. And this is a very nice website called Socrative. It's a free to use website. All of us can use it, and it helps us to evaluate things better. Once we have done that, everyone goes through this particular model. In the morning, we have the laparoscopy session, and in the afternoon, we open up the cadavers. So every delegate who is going to be a part of it goes through all the steps. There are checklists which are kept in place so that each one goes through all the particular steps, hand-holding by the faculty members. And there is a discussion which keeps on happening through the days while they're performing the program, because it's very important to give them a hands-on experience while they're doing it, so that they understand all the technical nuances of the particular procedures. This is how the team gets prepared. So we've got scrubs which are already predefined for each one of them. They get in a special package, and when they come in there, they are all ready to go in for starting the procedure. We put devil is in the details. So we put every possible small thing available for the programs. I have been into different centers, and sometimes you may have a particular instrument is available, it's not available, but it's important that you have a tray ready, which includes all the possible small things required for the cadaver, because we do an endoscopic procedures in the morning, and then afternoon it's an open procedure. So you need open and laparoscopic sets as well for that. This is where you can see all of them in action. And you can see those colored pictures. So as a part of making the program more vibrant, we give them all colorful caps. So these are designed by our team so that the whole atmosphere in the cadaver lab is more enthusiastic. Here you can see people are in action. There are operation theater lights. So it's like a live surgery which is going on there. And everyone is dedicated to see what exactly you have to do. In terms of cadaver dissection, these are some of the models from our fresh frozen cadaver. This is not a real-time patient, but this is an anterior component separation technique. Each and every landmark, you can see the quality of the muscle which is there. But the moment you will see a formalin or a thigh embart, you'll always find it's very sticky. The color changes. There's a lot of smell. I'll tell you, mask even is not required when we are doing these dissections, because in fresh frozen, you do not get any smell at all, unless you are at the end of the day where you're going to put it back into the temperature for the next steam. This is again one of the models of the anterior component separation technique. Now this cadaver is about 2 years, in the fresh, kept in the freezer at minus 20, and you can see the quality of the muscle even after 2 years. This is again in the tar plane which has been shown. Look at the anatomy. If you see on the abdominal wall, how nicely you can see the separation of the preperitoneal and the pretransversalis layer. Now, this is something which is extremely difficult for anyone to understand in the real-time situation. So when we teach these things, and when we see David and everyone talking about the anatomy, here you can show that on the tar muscle on the upper part, you can see that we have gone pre-transversalis, but in the lower part, we have gone pre-peritoneal. So all these small details about learning of the TAR is very, very important when we do in the cadaver model. And whenever we have done this, students and the delegates have learned it very well. Demonstration of the central tendon of diaphragm. M1 hernias, extremely difficult. If you do not know the anatomy well, one can easily enter into difficult cases. I remember Dr. Ramana talking about one of the cases where you actually got into the pericardium. So these kind of things can happen, but if you know the anatomy well, in the cadaver, you can do that. In the later part of the day, when we open up, we teach them in details about the neuroanatomy, because today we get patients with chronic groin pain, and one of us may have a patient where we may have to do the dissection. This particular anatomy is how it looks like. So this is dissected by me just for the educational purpose, and we teach them this in details about how the nerves go, where is the quadratus lumborum, what is the course, and everything is taught them in details, because sometimes you need to understand the anatomy very well, like how the ilioinguinal nerve can go very close to the aces and can go into the groin. So people who are tacky surgeons who like to put tacks everywhere during a TAPP, they have to be very cautious that if you go close to the aces, you can sometimes have a severe inguinodynia because of the anatomical course. So what has been my journey so far as this particular group is concerned? I come from this mad world of the cricketing fans. This is one of the stadiums where we play cricket. So if you see my case mix about my workshops, I have done about 2 open hernia surgery sessions when we were training our residents. We have done around 3 of the basic laparoscopic courses. I have been a mentor in AWR sessions with each one of my team members. So we have done about 12 so far. In the European Hernia Society, I have done 3, so I've been continuously going for the last 3 courses as a faculty to teach people. And finally, I think my big jump was this particular meeting where I got an opportunity to work in the American Hernia Society and be here with all of you today. So we've trained 170 surgeons so far across all the sessions. We've got certification by experts for them. And this is our paper published in Hernia, where we have gone into the details of how you can make a meaningful impact in training the residents. So what we did in this paper was all the residents which we trained, we went through all the questionnaires with each one of them. And if you see on this rain cloud plot, there has been a significant change in their practice. Before the cadaver, they were not confident about doing an ETAP inguinal or an ETAP RS, but post the cadaver dissection, there was a significant change and the confidence level was much better, and they keep on giving us feedback about how to do the training sessions. So what's in for the future of the cadaver training? I think we will have to slowly move into these 3D print models. These are specific models which have been designed where you can see the anatomy very well, because cadaver availability is an issue which works from different countries in different ways because of the rules and regulations. We also have something which is known as a synthetic cadaver, which is known as a syndaver. These are made out of different plastic models. I think this is going to be the future, but cost is going to be a major concern as far as these are concerned. So slowly, if you look at this particular article, which is in one of the clinics paper, 3D printing is probably going to replace cadaver training. We don't know the real answer yet because we still have not much of a paucity of cadavers as far as most of the countries are concerned. And there are some certain papers which also talk about home-based model. So each one of us is trying to get into a way where we can train surgeons today, because the problem is that in India, we have got lots of residents now who are getting the training system, but the number of hours which we work are going to be the same. So we need more models of how we can train them in anatomy so well, because we understand today anatomy is going to be the key for everyone. This is again a use of cadavers, so a lot of research we can do it. If you see Dr. Yuri Nowitzki's group, when I had been to Cleveland for training, in the PIC model they have done so much of training, and they have done all the experiments to understand how much of pull and retraction, midlation we can get it for the hernia repair. Guys, finally, I would like to say that I have learned a lot from international networking. So it's a key that we be in touch with each other and learn things in a better way. This is in the AWR meeting in Delhi, where we had all these faculties from all the parts of the world coming in there, and they help us for this kind of training because we can learn from there. That's Nat, who is the educational secretary for the EHS. He keeps on helping me, Fernando, because these are the guys with whom we can exchange our knowledge and know. This is in the European Hernia Society meeting. That's Johan. I make Johan do live chalk drawings when we do the cadaver workshops, and that's one of the main ace thing which people come in for because they love his particular drawings. This is again with the EHS team. And finally, this is with the team where I keep on going, and thanks to the American Hernia Society, David Chen, Yuri Novitsky, Miguel, from which we keep on learning. And I welcome you all for our meeting, which is going to happen next year in March in Chennai, where all these experts are going to come. And we have a very big course called the Body Lab, which is a cadaver lab program where all these international guys are going to come and teach you. So thank you very much. So to conclude, ladies and gentlemen, cadaver sourcing is very, very important. We need to understand the training guidelines. I think it's time that we have a universal international guidelines coming in as far as this is concerned. We are taking an initiative for that. Cadaver training manual and protocol is very, very important, so you do not have a haphazard training. And logistics of preservation and cost is going to be crucial. 3D printed model is going to be the way forward, but cost is going to be something which is going to be prohibitive there. And I think collaboration with sessions like this, American Hernia Society, European Hernia Society, is very, very important for us to come together and do some brainstorming sessions. Thank you, AHS, for inviting me here. Thank you, chairpersons. Thank you, all of you. And thank you, Dr. Flavio, for letting me come here. Thank you.
Thank you for your lecture. Are we broadcasting from the lab yet? Okay, so we're gonna have just a small change in the order of the procedures. We're gonna start with Vedra. We'll do anterior releases, preperitoneal dissection, and paniculectomy. Dr. Vedra is an associate professor of surgery at North Carolina. So Vedra, we can see you. If you can talk to us,
Great.
explain to us what you're going to start.
Can you guys hear me?
Yeah.
Yes.
Oh, great. Okay. Thank you so much. Super excited to be here. With me, I have Sarah, who's a Uri's fellow at Columbia, and I have Kyle, who's Conrad's resident. So they're going to be assisting me. All right, guys. So I'm going to show you the patient here. So First, we're going to do a paniculectomy, and maybe this is not the right size patient for a paniculectomy, but it's going to really help us with the exposure for the anterior oblique release. And we're also going to do a preperitoneal repair. All right. So usually, let's say she has a hernia somewhere right around here. Okay. And then let's say she has an incision somewhere down here. A lot of these patients are going to be consented for a paniculectomy and also an umbilectomy at the same time. So what we're going to do here is we're just going to mark this out, pinch it up. I do want to incorporate any incisions that you possibly need to take with yourself. And the skin here is usually very thin, so you have to be very careful not to make these incisions too low down, okay? All right, so now we're gonna get a knife, and we have a nice little 11 blade here, so I'm gonna try to do this with an 11 blade. We're gonna go down all the way to the fascia. And usually in the OR, we're gonna be doing this with a Bovie cautery. And I will have a resident do their part, and I can maybe have you, Sarah, do your part on your side. Do we have any towel clamps or anything like that? This is kind of the usual procedure. I don't know if we have any of our residents in the audience, but they know that we just, everybody takes their own side. So we'll do maybe some of those pokers, we can use those. All right, so Sarah, you're gonna start on your side, and you can grab whatever you wanna, you can use the knife, and I can maybe use the met scissors. All right, so we're just gonna start going. And here, you're just basically gonna be taking all the subcutaneous tissue right down to the fascia, okay? So it's almost like doing a mastectomy. You're going to be right on top of that fascia. And once you get closer to the hernia sac, the most important thing is really not to injure your hernia sac. Let me go ahead and see that knife. Maybe I will do that a little bit better.
Vedra, Stott here. Can I ask you a question?
Yeah, please. Who's this?
So you said that this is probably not the most feasible patient for this procedure. When do you think this procedure should be part of your initial strategy for abdominal wall surgery?
Well, I'll be honest with you. I do paniculectomies just depending on, the size of your hernia, the size of the skin that, the hernia dissects out, the hernia sac is poking out. So even skinny people like this lady here, will end up sometimes with a paniculectomy. You may not get approval for a paniculectomy if she doesn't have like a pannus hanging over the pubis and irritation, skin irritation and things like that. But I think anybody who's got a big bulge, where if you were going to do it robotically or something like that, that skin, is going to be hanging and it's not going to look good cosmetically. I think they're appropriate candidates for a paniculectomy. I think another really important thing with a paniculectomy is that you have you get a great release on your anterior sheath. So it's not really a component separation, but it does really release that. So the other thing is that you really want to minimize the amount of dissection. So if your hernia is here, there's no reason for you to be making huge flaps all the way out here laterally and killing all these perforators, okay? I'm just gonna do it for demonstration purposes because we're gonna do an anterior release, but you really wanna just limit your dissection to exactly where that hernia is, okay? If they have diastasis or something like that, maybe you can go a little bit subxiphoid and incorporate that as a part of your hernia repair. Okay, so you can see here, we're just gonna go all the way up on this. All right. So this is
Anyone
her
in the audience want to do some questions, please go to the mic.
So, Vedra, one question. I saw you excising the umbilicus. Back home, our patients are very sensitive about saving the umbilicus. Even the plastics would recommend that. So, would you take a different incision if you want to save umbilicus?
Yeah, so most of these hernias are going to be going through the like the umbilical. So you get blood supply from basically two different areas for the umbilicus. One is from the skin, and then the other one is going to be from your umbilical stalk. And if your hernia is going through the umbilical stalk, you're not going to be getting blood supply through there. And then if you take the skin away, so plastic surgeons usually don't fix those small umbilical hernias, so they don't knock the blood supply for the umbilicus, okay? And that's why they're able to kind of circle it out. Now you can come back in a delayed fashion and fix those umbilical hernias. But initially, if you, you're only going to have, if you were to circle out the belly button and take all that skin away and then put stitches underneath, you're going to kill that belly button. So, and you can, use SPY technology and take a look at the perfusion. I mean, I think all of that is absolutely okay. But we know, I mean, what's going to happen. I think the most important thing is you got to talk to the patients about it. And if they're very sensitive, they don't want to lose their belly button, then you absolutely, should not do it. You should just offer them a different repair. Just say, well, this is not going to work. So now if you have patients, who have like, subxiphoid, they've had a liver transplant or something like that, you're leaving their belly buttons alone. You're pinching the skin up here, you're excising those Mercedes incisions and doing your paniculectomy up there. But it's really going to be hard for you to excise skin and then pull that belly button down because it may end up down here. So you can always make a belly button. I've talked to some people about this, but if you kind of defat the fat all the way to the dermis there, then you can take a stitch and you can actually stitch it down. So it's, it's not going to look as good as a native belly button, but we can make one later and it looks pretty good actually. So I think for some patients, you can just give them a new belly button. All right, so the first thing we're going to, go ahead.
How high would you raise your flaps? Approximately up to the subcostal area you would go in, or?
As big as your hernia, yeah, you're going to be getting a lot of perforators coming in here. So I would limit your dissection until you can see good edges of your fascia. Now, if your hernia goes all the way up here and it comes all the way onto the sides, then you have to get to the fascia all the way laterally. But if most of your hernia is here, you don't really need to go all the way up and do that whole dissection. It's just kind of overkill, and then you may have more risk of complications. Same thing is if your hernia is above here, you don't want to start your paniculectomy down here because then you're going to have to take all that, you're going to have to raise that very large flap and kill all those perforators. So you really want to pinch the skin right where the hernia is and cut it off there. And, I tell all of my patients, I'm not a plastic surgeon, this is a paniculectomy, this is not a cosmetic tummy tuck. So it just really kind of depends. The patient selection, I think, is very important, and them having an understanding of what you're trying to do there. I don't know, around the world, these are very expensive procedures. I know where I am in Charlotte, it's about $35,000 for an abdominoplasty, and a lot of patients just don't have that. But we've tracked our outcomes for paniculectomies. with ventral hernia repairs, and actually decreases your long-term hernia recurrence. And I think part of it's just taking all that skin. You know, once again, this lady is very thin, but in some of our other patients, as you've seen, you know, removing all that skin, especially when it's filled with a lot of intestine, you know, once you reduce the bowel back into the abdomen, that becomes like an envelope for seroma formation. It's going to break your wound down and it's just going to look bad. So I think that's why it's important in certain patients just to cut that skin off. Okay.
And you can create a pretty large preperitoneal pocket despite not creating very large subcutaneous flaps, right? And that's typically what you do
100%,
to have for your
100%,
mesh.
Yeah, you can
Yeah.
keep all this down all the way. And then we're going to go preperitoneal. So I'm going to show you guys real quick how we get preperitoneal. So the best place to start is to go down into the space of retius. I don't know if you guys can see here. So the feet are this way, and Sarah's holding up the
Yeah.
abdominal wall. And you can see here, this space really dissects quite easily, bluntly. And you're in that same space as if you're doing a, you know, lap inguinal hernia or robotic inguinal hernia. So you mobilize that, you'll feel your Foley balloon usually. And that's the best place to start your preperitoneal dissection. And then I'll show you here, if we have another coper, so we can lift this up. I think there's a belief that the peritoneum is super thin and that we're not able to really take the peritoneum down circumferentially, but I think it's all about kind of where you start. And what I'm trying to do here is essentially go all the way out laterally here, okay? And you guys see where I am right now. I'm all the way preperitoneal. I know I'm not posterior rectus sheath, okay? Because I'm going to show you guys that. And then this peritoneum, just from that lateral direction, it'll strip all the way down. And that just kind of opens it up there for you. So let me have a sponge stick and just one of these little Ratex here. So you can then push the peritoneum down. That helps you hold it. And then you get all the way out here. I don't know if you guys can see this, but this sponge
Yeah,
stick,
we can see you.
you can go all the way out laterally. If they have an inguinal hernia, you can take that down. This is her round ligament right here, okay? This is her internal ring, and then you can cut the round ligament. That's not a big deal. Obviously, if it's a male. Oh, okay. Can you guys see this? So this is the preperitoneal flap,
Yeah, we can.
okay?
It's
And I'm
very
all the way
good.
Yeah,
left.
we have a great
Vedra.
view.
Yeah.
And there's Cooper's
We
right
can see even
there,
the
you
round
know.
ligament when you're.
Yeah, round ligament, I've cut it. Let me see if I
Yeah,
can.
we could see. We can see
Oh,
when
you can see it.
we
Okay,
are
perfect.
handling.
All
Yeah.
right, so now you're just kind of
Perfect.
gonna make, and often I will do that, you know, inferior first, and then you just go subxiphoid. So there's always some fat in that subxiphoid area, and you can go there pretty bluntly. There's always a little bleeder up there, so just make sure you get that. And you're in the preperitoneal space up here. Now your peritoneum is gonna get real thin right around the diaphragm there. So that's just something to keep in mind, because in somebody who has a very thin peritoneum, what you can do is you can pop into that pretransversalis fascia. You can see here we have bare muscle and then we have transversalis fascia. So you can use that. You know, if somebody's got a good peritoneum, you can just stay preperitoneal all the way. But if it starts ripping like that, what I'll often do is I'm going to go and get pretransversalis. And, you know, I'll use like a Kittner or something like that. Here's just tearing a little bit. And then you can go even further out, more laterally with your fingers. And you're basically, the basic maneuver is you're kind of going from lateral to medial and bringing it to yourself. Because if you start here medially, you're just gonna make a lot of holes in the peritoneum. But I'm all the way up here underneath the diaphragm, kind of just bringing that peritoneum all the way around. And then you can connect your fingers here. Okay. Amputate this, or you can just scissors or something. Oh, they're right here, sorry. All right, and then, going away. And then you can get really far up in here. I don't know if you guys can see this or not, but there's a diaphragm
Vedra, is
up
it
there.
possible for Vedra? Is it
Yeah.
possible for someone to put any kind of light?
Light,
Because we
yeah.
can
We have
see
a
your
cell
hands
phone.
working down there.
Uh-huh.
Yeah.
It's a
You know,
good,
like a cell phone light. Yeah,
yeah,
I
yeah,
think we'll
that's
be
exactly
just
what we
that.
need. Can somebody shine a light maybe over my right shoulder here? Look down or up? Okay. Yeah, I don't know if you guys can see here, but yeah, So here's your transversus abdominis muscle. You can see some transversalis fascia, but the whole perineal flap is here, and I made a little hole there. You would take it down the other way as well. But then for all these holes that you make, here's your omentum. You got a nice omentum. You can put that all the way down underneath the bladder, and then anywhere where you have a hole, if you can't close that hole for some reason, you can just use that omentum and then just whip stitch it around in a circle. You know, you often get into those problems when you have really obese patients with very thin perineum and you make a hole somewhere up here, and then that becomes a little bit more difficult. But you can basically do that on that side. You can do a tar on the other side if you'd like, and then you can join these two layers. Use the posterior sheath from the tar if you want to get a release on this side, but you don't need a release on that side. Or if you want, you can do preperitoneal on both sides and not do any kind of component separation, okay? So any question about the preperitoneal repair before I move on to the anterior release?
No, it's very well demonstrated. Congratulations.
We have a
There's
question
one
from the
question, sorry.
audience.
Please,
Perfect,
go
okay.
ahead. Of course. One question for the audience.
Yes.
The vertical incision, and then we convert into inverted T. So, and then many times we get a necrosis at the edges. So how you do paniculectomy at that time?
You get necrosis
So
where?
did you hear the question?
I heard the word necrosis at the edges.
They start with an umbilical incision and go down and do an inverted T and then get necrosis at the edges. So how do you
Oh,
deal
yeah.
with your paniculectomy?
You
in that
should
case?
try to avoid T incisions as much as you possibly can. Other things, if they've had a subcostal incision and if you do a midline, you know, that's where all your perforators are. So that corner right there is going to be at risk of ischemia. So anytime you can avoid the T incisions, I think try to. Now, there are some patients that have, it's going to look a lot better if you go both ways, and then you can really kind of give them a waist. But that does come at a cost of, you know, getting a little bit of skin ischemia. But honestly, pre-optimization, making sure that these patients are not morbidly obese, that their hemoglobin A1C is under 7, that they're not current smokers, you know, not on prednisone and other steroids, that's like 90% of the job, I think. And then just trying to kill the least amount of perforators that you can.
How do you
Okay.
handle the soft tissue once you've done the paniculectomy?
Oh, you mean
How do
like
you-
just
how do you-
this? Or
Yeah, how do you
Oh,
use
yeah.
a Prevena?
Sure.
What do you use for the
I
soft
do,
tissue?
I do, yeah. So when we've done everything, we put one drain right on top of the mesh, close the fascia, put one drain in the subcutaneous space, irrigate with lots of antibiotic irrigation, and then we'll use some kind of a product that has hemostatic properties. You know, there are a lot of different ones. You can use glues, things like that. I think binders are the best thing to prevent bleeding after paniculectomy. So we put those pretty tightly on everybody post-op for about 36 hours. And patients like it for comfort as well. But yeah, I'll usually use 2 monocryls interrupted right here. I usually don't do any quilting stitches, but I think you can do that. And then I will staple, and then we use a Prevena. Prevena has really, you know, I think any one of these negative incisional products has been very helpful to reduce post-operative infection. So I definitely, you know, I used to make fun of these when I was a resident, and I'm a huge believer because we've looked at our data, and the Prevena definitely makes a huge difference.
Better, have you used ICG before the flap closure as a mitigation strategy to prevent flap necrosis?
Interesting that you asked that, because we actually did a double-blinded randomized study on that, and it was plastic surgeon versus the SPY. And what it turned out to be is that a well-trained plastic surgeon was just as good as the SPY technology as far as predicting what needed to be cut off. Because we would have him blinded, you know, and then we would use the imaging and figure out what was, because you could see the dark areas, you know, and what needed to be cut off. So I think, you know, just minimize the size of your flap dissection if you can. You know, because you're going to see these little perforators all around, especially down here. You know, don't go in the Mons area. Some of these patients have like a really big Mons. Don't dissect down there. That is like full of lymphatics. It's going to fill up with fluid. It's going to look terrible. So just don't do any of that. Don't undermine if you don't need to. If you have any crossing incisions, you need to cut those incisions out so you're not undermining under these, you know, transverse incisions.
Okay.
All right. So next thing
Yeah.
I'm going to do is just going to show the external oblique release because if you have like a really, really big defect, you're already kind of in that plane. And the way Dr. Ramirez described this is that you really feel where your rectus muscle is, you feel the semilunar line, and then you need to go about 3 centimeters laterally. So you can see that, you know, if we didn't have a paniculectomy, that would be a really kind of large flap. Oh, wow, we got a 10 blade, sweet. All right, so then I will usually feel that external oblique muscle, okay? And you can see that the fibers of those muscles are going to be going like hands in the pockets. It's going to be running down towards, it's going to be going down this way. And your internal oblique is this way, transversus is this way. I'll give you this back. Do you mind if I get a pair of scissors? So this is an avascular plane, okay? So I think what's really important is you can, you don't have to make these huge unless you need them. Obviously, you're not doing an external oblique release unless you need it. But you can see that the muscle really separates very nicely. If it's not separating, you may not be in the right area. And the nice thing about the external oblique is that, especially for those big M1 defects, you can go way above the costal margin here. So if you really need to have a lot of advancement medially here, you know, this muscle actually attaches above your costal margin. So you can go all the way up here and take it all the way up to the costal margin. You're going to have a humongous mesh in your preperineal space here. So you don't have to worry about that, but it's really going to help advance it this way. And then the last thing in your internal oblique release, I think that's important, is that you're really separating the muscle if you need to. You know, if you need to pull this over, you're going to get all the way in here. Grab that extra, actually just grab the muscle there, yeah. And then you really separate this. You're going to see a lot of this kind of fibroareolar tissue, and it's a very avascular plane, and you can go really far out there, release this.
So how
Okay.
far would you go laterally, Vedra? Because there's always a constant perforator, and when we train in models, we tell them that somewhere near the anterior or the mid-axillary line, you get a perforator, and that's where your end point of the lateral dissection should be. Your comments on that?
So
The
honestly,
lateral dissection.
I have gone pretty far down here, and it's very rare to see any blood vessels. So I would only separate this or go as far, you know, depending on how much you need. Because if you need to separate it a little bit and you already can close your fascia, you're fine. But if you can't and you need more advancement, then you can travel further and really get your hands in there and open this up. And then, you know, if you can't close the fascia after you've done this, there's really, I mean, the only other thing you can do is take the posterior rectus sheath, which is the way Dr. Ramirez described that. And that's kind of as, you know, your start to the TAR here would be that same muscle separation. You would just open this up. So this probably gives you another couple of centimeters. Okay, so you're just not doing a TAR, but you're just opening this up. And this is pretty much the maximal release you're going to get. You know, this external oblique, posterior sheath release, and that's how far it's going to go. And then your mesh is going to go way out here beyond this cut edge of the external oblique. I'm actually going to put my stitches, my anchoring stitches right here. I'm going to put my anchoring stitch into the external oblique, and then you have a layer of mesh, your internal oblique, transverse abdominis. So you have a little bit of extra enforcement right there.
And would you put in an onlay mesh as well? Or because sometimes you see those bulgings post-operatively in the areas where you've made the release. So how do you tackle that?
Yeah, I
the
mean,
top.
so, you know, if you're using, you know, meshes that, you know, I don't see bulging because the mesh is all the way out here laterally. I guess if you had a very
Okay.
thin internal and transverse abdominis, you know, that patient probably has a pretty rotund abdomen, but you shouldn't see any kind of asymmetrical bulges, I don't think. I mean, especially if you're using a synthetic mesh, I mean, it's going to be pretty good at preventing any kind of bulging there.
Okay.
Any questions before we move on to over to Dr. Chen's demonstration?
Yeah, we have another
The
question.
lower limit will be inguinal ligament. Lower limit of your incision on the external oblique will be inguinal ligament.
Sorry,
What is the lower limit extent of your dissection? Is it the inguinal ligament?
yeah, I mean, you can go pretty far down. Just don't go all the way down because you're gonna be in that space and you're gonna cause inguinal hernia. So I really try to limit this because you're not going to get much more release down here anyway. You probably are going to get more release by making a bigger subcutaneous tissue flap down here inferiorly.
Yep.
Vedra, this is Ram. Question for you is, when you design the abdominoplasty incision, you typically have a C-section scar over there. And I always worry about going through the same scar or just below it to excise it. And then when you close it, you're potentially pulling the mons pubis further up. How do you plan to prevent that?
Yeah, so you excising old scars is totally fine. I think if you have one scar and then another parallel scar, I think that's where you're going to have issues possibly with perfusion. But if you go all the way down to that scar, I think you're going to be fine. Making the mons come up too high is something you should worry about. I heard of a case where the lady was peeing straight out like that because they had pulled it so tightly, so they had to revise that. So I wouldn't mess with the mons too much. And honestly, most of my patients, even if they've had a C-section incision, I'm usually not going to that scar, you know, because most of our patients are very obese. The last thing you want is the break where they, you know, sit in the chair to be in that area, because that's the highest risk of the wound breaking down. So I usually am making my incisions higher up. It all obviously depends on the hernia. But somebody who's skinny, somebody who's healthy, I think you're totally fine to take out that C-section scar and try to give them as much of a abdominoplasty look as you can, and then make them a new belly button if you can as well.
Thanks.
You mentioned that they're very obese. Do you have I mean, we talk about this with prehab and weight loss and everything else with these reconstructions. Do you have a cutoff for BMI in these patients, or because of their pannus,
it's a good question. I mean, in our studies, I think the average is about 35, 36 on the BMI. We pretty much try to make everybody lose some weight before surgery, even if it's 10, 15 pounds. I explain to them it's like packing a suitcase, and even 5 pounds the size of a football, the volume of the fat. So even if they can lose 10 pounds before surgery, it's going to reduce the need for, you know, it's going to be a more tension-free repair. Maybe they won't even need a component separation. So I do try to get them down, but once you get to BMI of, you know, 39, 40, we definitely need to lose a little bit more weight. Over 50, 60, I mean, I think all of those would not be elective surgeries. So definitely try to, you know, under 40 would be for the elective cases if at all possible. Now, if they've lost 200 pounds, they're symptomatic, otherwise optimized, you know, we'll do some of those higher BMIs as well.
Great. We have another question from the audience.
Dr. Vedra, I'm Dr. Suarez from Mexico. With those kind of huge dissections, the probability of bleeding of seroma in postoperative time is high. Do you recommend the abdominal binder, or there are some descriptions about to use glue in this kind of patients? Even I think you put a drainage, but do you recommend abdominal binder?
Yeah, so we actually did a study, Dr. Hennifer did a study on looking at seroma formation in the sub-Q space. And talc actually was the most effective as far as obliterating the amount of seroma. So the same talc that you use in a pleural cavity, we would spray the bottle of talc in the subcutaneous space, and that really reduced the amount of time that patients had to keep subcutaneous drains in. Unfortunately, we don't have that product on the market anymore. So now we just use drains. I think minimize the dissection. I'm a huge believer of binders. We keep those on for at least the first 2 days, and you know, patients often keep them longer. But I think a tight binder is going to really be helpful with compression. Most of these patients, you know, they start out with a blood pressure in the 150s, 160s. When you're closing them, that blood pressure is always about 100. And what happens is that some of these little veins that you cut and cauterize retracted back. So when you close the patient and they go to recovery and now their blood pressure is back to 160, you can get some of those to rebleed. Because when we take them back, and our rate of hematomas is about 3%. And those are hematomas that have to go back to surgery. So that is, you know, it's 3 out of 100 patients that you have to bring back to surgery, and that's not fun. So what I do also before closing, I will squeeze on the subcutaneous tissue flaps, and often you'll see huge squirters, and try to get them before then. You know, so those are just some things, but I think binder, it's a great strategy.
Thanks.
Great.
So-
Oh,
Sorry. Thank you, Vedra, and we should move on.
Sounds
Thank you
good.
for a wonderful dissection, and everybody is gonna give some claps for you.
yeah.
Oh, thank you. Thank you, Dan. Thank you.
All right, and we will move on to, as Conrad calls him, Yoda Chen, for his opening little groin dissection and neurectomy. So David, if you're ready to go.
Then I just roll like this.
No, it's okay.
Get somebody to.
So if you can go to David Chen, please.
Yeah, we're switching over the mics. We have a high-tech setup here. You're even to be an AV guy.
Oh, yeah. It might be as good as.
All right, so we're gonna do inguinal demonstration, and in order to understand open, I think it's best to also see it laparoscopically, or from a posterior side, because then you have a better understanding. And so what we're gonna do is we're gonna start. Can you guys see the body right now?
Yeah.
Yes.
Okay,
Yes,
please zoom
we
in
have
a
your
little
video.
bit on that. Yeah, they can. All right, okay, we're gonna zoom in a little bit on the body, and I'm just gonna orient you. Okay. All right, so I've set it up basically. This would do a laparoscopic operation, but I have one port intra-abdominal. The normal setup for, dang, this thing is heavy. So, all right.
We don't see you,
This
David.
won't
We
work?
don't see you. We do see a body, but we see.
Okay, they can do, yeah, they're gonna do 1 feet at a time. So I'm gonna show you what we have here just for orientation. Okay, you can see the body here. Okay,
Yeah, we
Yeah.
can see it.
this is the xiphoid process here, right here.
Okay.
Pubis down here, okay? I put 1 port intra-abdominally to prepare for this, and then this is like the normal TEP setup. You'll see it here, here, and here, okay? So that, or whatever you want to do, or here, 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 whatever you want to do for a TEP. So we're gonna start now. Let's switch over to the laparoscopic view. And so I'm gonna show you guys a laparoscopic intra-abdominal view. So can you guys see the laparoscopic view now?
Yeah, it's just small.
There we
Yes.
go.
Right now we are split videos, so we have the
Laparoscope.
central view and the intra-abdominal view.
Okay,
Yeah,
so
we have both.
okay, so now I'm inflating intra-abdominally. Okay, so this is just here you can see from the outside. I'm gonna go from this port that I put in as an optical trocar, which is always like the whole concept of ETEP. If you want to take a peek from the inside, is always helpful. Can we go? Is it flowing? All right, there. So here, what you can see is, can I get that suction? Okay, it's in the trash can. All right, so this is the intra-abdominal view, and we're gonna try to get that to increase. Yuri's increasing the flow here. Okay, so just for anatomy here, I'm gonna suction out some of this. Can we turn on the suction, please? Okay, so this cadaver has a little bit of stuff here. So these are the plicae, right? So we talk about the intra-abdominal anatomy here when you're looking and you're doing a TAPP. So if you're doing a laparoscopic TAPP or a robo TAPP, these are the intra-abdominal landmarks. We don't have full insufflation. Is the tank, can you drop the flow? Yeah, put the flow higher. Good. There, that's better. Okay, can I get a Ray Tech here? Sorry about that, guys. Okay, here. So just for orientation, okay? If you have a intra-abdominal, trans-abdominal view, here's the bladder, okay? This is the left medial umbilical ligament. This is the right medial umbilical ligament. This is the median ligament forming, this is the urachus, right? The medial ligaments come from the iliacs. This is the lateral plicae. You actually don't see it in this patient because it's fat peritoneum, but the lateral plicae would be actually you can make it out here, the infraepigastric vessel here. And this is the right lateral umbilical ligament right here. So These are your landmarks for intra-abdominal, that if you have an indirect, it's lateral to the lateral. If you have a direct, it's medial to the epigastric and lateral to the medial umbilical ligament. If you have a femoral, it's below. Same thing here. This would be femoral, direct, indirect, okay? So that's your intra-abdominal view. And remember, anytime that you're learning ETEP and you're learning extraperitoneal anatomy, it's okay to be intra-abdominal for some of the views. And so what I'm going to show you is that if you have a spacemaker, can you give me the little pumper, the blue pumper over there? So this here, I put in a spacemaker here. You can see on the outside, here's a spacemaker balloon. And so for all of you guys that do TEPS and you didn't know what it looks like, you can, this is kind of a little way that you can see, okay, when you use that TEP balloon, this is what's happening. Okay, so this is a spacemaker balloon or whatever balloon you use. And so Jorge Diaz just understands this anatomy so well, he doesn't need a balloon, but you see, this is what's happening. The balloon in the center of your field right here, that's the balloon trocar. That's a dissecting balloon, and it's making this space, right? And so that's what's happening when you dissect that. And then we can deflate it. And then I can remove that. And I can easily then switch my insufflation from being, you want to vent that, from being intra-abdominal to extraperitoneal. And hold on, go ahead and pull out this. So now I'm going to pull out the dissecting balloon, and you're going to see what happens in this space. It just blows that up. So just remember, anytime that you're having trouble learning ETEP, take a peek. As long as you don't violate the planes, it's wide open there. Okay, so now what we're going to do is I'm going to leave this camera here. We're going to switch to a 30-degree here, and I'm going to look from extraperitoneal. Okay, so now we're going to have an extraperitoneal view here. And now you can see this same anatomy. If you understand this from each side, you'll always be better off in life, okay? So here, this is the arcuate line, and this drops off into your preperitoneal space. Now you wish that the balloon gave you this dissection, but I worked at it a little bit right before this, especially because this patient is a little bit fatty, and we don't have the time. So I'm going to show you then this anatomy and point out this anatomy from the posterior side, so that when we go open, you'll understand it all quite clearly, hopefully. Okay, so here now.
David, I want to buy that balloon.
Yeah, this is the balloon that this is the new Medtronic balloon that does a perfect dissection for you. Gives you, it's called the critical
balloon.
It's called the Felix Diaz balloon. So here is the midpoint of the symphysis, right? So this is your medial umbilical ligament, the remnant of the median umbilical ligament, the remnant of the urachus, right? So if you have a urachal cyst, it will run along this. Here's Cooper's ligament, right? So, and then here, as we look at this, this is your myopectoneal orifice. And this is what we're striving for, is if you followed your 10 commandments and followed Jorge and Ed Felix's papers, you'll get this view at the end, and we'll look at this anatomy and show it. So first space that you want to see Cooper's ligament. And I always like to think of this, you know, our Brazilian friends talk about this as an inverted Y right here, and then the Y here. And I always tell the residents like a clock face. So this is the center of your clock. This goes to midnight is your inferior epigastric artery and vein. From 12 o'clock to 3 o'clock, you have your indirect space. From 3 o'clock to 6 o'clock, you have this is your electrical triangle. At the 6 o'clock margin is your inverted Y. You have vas deferens and spermatic vessels. And then from 6 to 9, you have your femoral canal. And from 9 to 12, you have your direct space. So that shows you all your spaces, okay? Now, when you look at this anatomy, you'll understand when we do the open part, that you can hold this, that you'll want to understand what we're looking for and what nerves we're looking at. So this is the vascular anatomy. You'll have epigastrics here. And this is why when you're doing a TEP, if this epigastric is not up, if it's down, don't blow up the balloon, because otherwise you'll avulse this branch here, sometimes you have a branch here, and sometimes you have a branch here, and almost always you'll have a lateral branch going this way. And when we do reoperative surgery, I always think about that because it will bleed when you're removing mesh. This is always reliable. Upper crosser at Hazelbeck's, lower crosser at Hazelbeck's. You have a crossing vessel that goes out laterally. This is the iliopubic tract. From here, this is the backside of the tubercle, and this is the ASIS here. You can see it very nicely. This is the iliopubic tract. David Laurier will talk about the transversalis arch, or the sling. This defines right here your indirect space, right? And then here on the medial side, you'll see this is the iliac vessel, iliac vein. This is the lacunar ligament right here. So if you have an incarcerated femoral hernia, you cut diagonally like this to free the iliopubic tract and the lacunar. If you have an incarcerated direct, you can cut here, it's relatively safe. And if you have an incarcerated indirect, you want to cut out and lateral. Now we think about the nerves here. And so on the posterior side, we always talk about why do posterior repairs have less pain in general? Well, typically because there's less nerves here. So you have to think about what are the nerves of interest? Well, the last branch of the lumbar plexus is this, the obturator nerve right here. And you can see if she zooms in like this, you can see obturator nerve here below Cooper's, obturator nerve, artery, vein going into the obturator foramen right here. The corona mortis will travel from the epigastric to the obturator foramen. This patient does not have a corona mortis, okay? What we're looking at here, so a corona mortis would come right here. This is actually here, was in the femoral canal, and I pulled it down, and you can see it has this fleshy appearance. This is Cloquet's node. This is the first node in the iliac chain, very relevant for oncologic processes, for a prostatectomy, for melanoma. It's the first in the chain for lower extremity melanomas, okay? So that anatomy, this is nodal, but it's important because these guys will like to bleed, okay? And then down here, this is obturator nerve, artery, vein, obturator internus muscle, and then these are feeders to the bladder. So when you sweep here, you want 2 centimeters below Cooper's ligament, but really not more than that. But I always like to see this. I tell the residents, in order to say I'm done, I like to see vas deferens, peritoneal reflection, artery, vein, Cooper's, obturator. And now I know this groove, there's nothing in there. So this would have been where the femoral would like to go through. Here's my peritoneal reflection here. I already dropped it down. And sorry about that. So there's the femoral, there's the, and you see the trick that she just did. So the view gets bigger if I cut this arcuate line just like Jorge would for an ETEP. You put the balloon past it and you pull back. And then over here, you can see now the lateral anatomy. Here's going to be vas deferens. Just float right over that. This is the spermatic vessels. Here's your iliac artery right here. This is your iliac vein right here. And you have a few different branches of the genitofemoral. So here you can see this is genitofemoral right here. Coming up here, coming off the psoas. So genitofemoral comes from L1, L2, L3, courses over the psoas. Focus that a little bit better. There. And you can see here, this actually is probably, I can't tell 100% yet if this is genital alone or, sorry, genitofemoral, and it branches like this. Femoral branch should go below the iliopubic tract. So this is probably femoral branch because the genital should head into the canal. So I'm going to then look over here and say, well, this is probably then the genital nerve right here. And so that can run right over the artery sometimes. It's anywhere from here to here, variably passing. So this is probably genital. This is probably femoral branch of the genitofemoral nerve. And then lateral, so this is the edge of the psoas. And this is no-go zone over here. Now here, this patient had a lot of fat, but I wanted to find the lateral femorocutaneous nerve. I think it's actually coming right here and going out. Why? Because the thigh is over right on this side over here, and it has to take that course. And now remember that when we talk about tacking, you always say I want to be below, so I want to stay, have everything above the iliopubic tract or medial. So if you, or Cooper's. Cooper's is the only freebie in life. You can put a tack at Cooper's and that's free. You can put up here in the rectus, it's probably okay, but remember the iliohypogastric, this is the backside of the conjoint tendon. So high and medial, probably okay. When Yuri Nowitzki tacks all of his flaps, he's probably just fine because he's up here. But don't do it, don't do it. So now below the iliopubic tract, pull this guy here, you can see this is where the nerves pass. So the femoral branch of the genitofemoral will pass directly below the iliopubic tract and go into the thigh. And that's iliopubic tract nicely here. Sometimes from the femoral nerve proper, there's an anterior femoral cutaneous nerve that also will pass there. And sometimes the lateral femorocutaneous nerve, which passes this direction, will go to the thigh, but can also have a feeder. So this is all electrical triangle. Now, if you're tacking and you're somebody who likes to tack, minimize the number of tacks because it's a volume-based risk. It's like playing Battleship. And over here, on a cadaver, we can show this anatomy, and we never want to be here lateral to the psoas. But if you go lateral to the psoas, and I'm going to rip this here, you'll see that we can see the femoral nerve proper. And so you never want to be in this space. It's quite robust. I don't have a perfect angle to get it, but this is here going to be femoral nerve. So you have to, you see in a patient that's heavy, the psoas really protects this femoral nerve. But if you tack right there, you can get it. So this is all going to be just this femoral nerve is going to be in this cable right in here. Okay, so no tax lateral, no tax low, and this here you can see when people get femoral nerve injuries, it tends to be you got to go pretty deep. It's a big cable. So usually they have anterior thigh weakness because you don't hit the backside of the cable, but femoral nerve is right in here. Okay, and so no tax there. Now we're going to start doing anterior anatomy now, and so I'm just going to show you theoretically like where that pops up when you're doing your operations. Okay, so here, if you have a piece of mesh here and you say, okay, I'm going to just tack here. Okay, you can see I'm going to put a tack there. Well, maybe I won't. Yeah, I put my mesh tack there. I'm out of tacks, but don't blame BD for this tacker. This was one that was just in the lab. Okay, so this one is not good equipment function. So this is not a fresh product. But what you can see is that all of those areas we'll see when we go to the anterior canal. Let me see if this will flow. Let's see if I can get one to fire. And we could just use that as an
Anyone
example.
has questions, please come to the microphone.
Okay, anyways, okay, so there we'll take a look at what that anatomy looks from the inside. But just remember, in general, and I'll show it here, that ilioinguinal runs in this course. Here, 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 here. Right in this plate, and you don't know where. Iliohypogastric runs right here, 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 okay? Why? Because this here is your conjoined tendon. How do I know that? This is the lateral border of the rectus. So in a Schuldeis repair, this is the ligament of Henle that David Laurier shows so nicely. The lateral border of this rectus. And what you're doing in a Schuldeis repair is you're taking the ligament of Henle and bringing it to the iliopubic tract. You're closing this direct defect by bringing this to this. And so, but the conjoined tendon is here. The internal oblique muscle, rectus is behind it. And so iliohypogastric nerve is here. And look how thin it is that I'm pushing on the cord structures here. That if you say I close the floor of the canal robotically because I'm so good at it, the problem is that you can sew right, this is the cord. So you can sew right through the spermatic cord, right through the floor. And so we've seen that a lot. And we're going to look at anterior anatomy now. So what we'll do is we'll deflate this. We can turn off the gas there. And can we switch over to this headlight now, or this head camera? Okay, so now I didn't do any of this dissection yet. So this is all, we have that feed. Can you guys see? Not yet.
Yeah,
We're
right
good.
now we have both external views, David. The one
Great,
from
but-
your head and the other one.
Okay, great. Do we have a light? Some kind of a light?
David,
Can you
David,
guys have a
is it
flashlight? Can
possible
somebody
to,
hold a flashlight?
quickly- David, is it possible to see the retroperitoneal anatomy from where the nerves would come in?
Yeah,
quickly, if
pay
it's
for the
possible?
course on Sunday.
Okay.
So that's on IHC Premium. You can talk to Brian Jacob about it. So here,
Okay.
here's the anatomy. So this is the midline here. I've marked out the pubic tubercle here and here. This is the symphysis pubis. This dot is the ASIS. Get up. This is the inguinal ligament here. Connects the ASIS to the tubercle. We typically like to make our incisions 1 centimeter above the symphysis pubis. Why? Because if you go too low, you won't be able to get to the anatomy that you want to for an inguinal. If you go high, you'll be reaching for it. Now, I typically make this a 6 centimeter incision, and when we do this, we can do this under pure local anesthesia. We'll inject 10 cc's under the incision. For somebody like this who's very heavy, we'll then go another 10 cc's of local, which is typically marcaine and lidocaine, into the sub-Q. There's always a superficial epigastric vessel that courses. It's right in the sub-Q. In this cadaver, I just blew through it, but that one you should pay attention for, because when you see it, you should tie it on each side for 2 reasons. One is that if you talk about what's the thing that bleeds the most in the inguinal canal, it's actually the superficial epigastric, not the inferior epigastric or any of the cremasters. And that's what gives them a hematoma here. So then what we do is we dissect down to the external oblique. And usually what I'll do is I won't do such a big dissection. Oh yeah, that's great. I will usually just get a little window where I see the external oblique fibers like this, and I'll take a syringe and I'll inject 10 milliliters directly into the canal. And what I can see when I do that is it will hydrodissect this canal. You should see it plump up immediately below the external oblique aponeurosis. If you don't see it plump up, you're too deep and you're probably in the cord. And if it leaks, you're too superficial. But when you do that, that's kind of the bulk, the lion's share of the block for the patient. So that's the 10 on the skin, 10 in the subcu, 10 below the external oblique, because that's what's going to give you the block of all three nerves. So now, here you have your external oblique anatomy. I can feel the ASIS right here. I'll mark it for, what was that?
Are you able to zoom in on either of the images
Like this?
by chance?
Yeah.
One of the cameras, I'm not sure.
They can zoom in the overhead, yeah. Okay, so this here, we can look over here. This is the anterior superior spine, okay? This here is the inguinal ligament running like this, okay? This here is the tubercle right down here, okay? This here, I put some dots at the center point of the canal. And what we're gonna do now is we're gonna pick, I look for this. I look for the decussation of the fibers of the external oblique where they split right and left. And that's where I can tell is the external ring. And it's a little bit hard on the cadaver, but let's see if we can see that a little bit better. Okay, good. So there, now we can make that out a bit. Light goes here, please. Okay, can you guys see okay?
Just zoom a little bit out. Was better before the image on the not David's head, the other one. Just zoom a little bit out, a little bit, because we're losing focus. Not your head, the other one. Just zoom a little bit out, just a little bit. Yep.
Is that better?
Yeah.
Okay. All right. So here's the inguinal ligament here. This is the center point of the canal. And I know that the fibers are decussating here. So the external ring is probably somewhere around there. So I pick a point in the center of this canal and I open it. Okay. So here. Now usually we'll do this.
Hey, David, if it's not too much trouble. So the image that zoomed in, your head is covering it. Is there a way that they can do how we do it compact where they hold a laparoscope over that?
Yeah, you can, Dr. Novitsky can, no, they can't feed the laparoscope and the headlight at the same time, but I can move. I can do it this way. Is that better?
Yeah. Way much better.
Yeah, perfect. Thank you.
Yeah, I can operate backwards. That's fine. Okay, so. So here, you can hold this here. And then, so with the Liechtenstein or any anterior operation, usually this would be hydrodissected, okay? And what I want to do here is I'm going to open up the external oblique aponeurosis in the direction of its fibers, right? And typically, you then want to open this to the level of the external ring. So let's see here. Okay, so. Okay, all right, another snap
here. It's perfect, my friend. Please don't zoom, it's okay. We can see very well. It's very good. We're gonna lose
approval. We're gonna lose ratings.
Yeah. No, we're losing some focus.
Okay, all right. So here, we're gonna start, can I get a peanut here? This is the best peanut we have here. Okay.
Perfect, we even can see the nerve.
Yeah, you will be able to. So here, when we do this, we dissect medially to the conjoined tendon, right? And I typically will do this with a peanut. And now what makes up the conjoined tendon? Well, the external oblique aponeurosis, right? The anterior rectus sheath, which is right here, okay? And then the confluence with the internal oblique. And on the internal oblique side, you have, this is the aponeurotic portion of the internal oblique, right? And then we're going to move this guy here. Let's keep working our way here. Okay, if you can hold this guy this way here. And I'll finish it. So, okay. 10 more minutes. 10 more minutes. Okay. Yeah, we're not going to fix it. I'm just going to show anatomy. Okay, so here, iliohypogastric nerve. You see that? Iliohypogastric nerve exits at the conjoined tendon, right? Okay. Hold on. Nope, don't pull that guy. Just leave it there. So, all right. This is a little bit. And then here on the other side, we're going to dissect to the inguinal ligament. Okay. So here, you can see down here, the inguinal ligament laterally. Let me just dissect this here. Okay. All right. And so here, this I sweep with the peanut to the level of the inguinal ligament. And I want to sweep it all the way. I usually would have a finer peanut than this, but I want to sweep it all the way to the tubercle. Okay. So here now, once I get that all kind of swept here.
Take your head out. Can someone cut Chan's head, please?
Yeah,
we can
yeah,
see
it's
the
a.
dissection.
Okay, so once that's like that, then I move the Wheatlander. The key to all good open surgery is retraction. It's the retraction provided by the Wheatlander and your assistants. Okay, so here. Okay, all right, so now I have this anatomy here. Where's my scissors? Okay, so you can relax on that, pull on this here. So I'm going to open this to the external ring. So that releases the external ring. Okay, and now I'm going to look for all three of my nerves. Okay, so iliohypogastric nerve we said was exiting right here. You can see it right here. Okay, this thing running over here, exiting at the conjoined tendon. I can make it very clear here. This guy coming through here. Okay, ilioinguinal will usually run right along the top of the canal here. And here we can actually see it. Let's see. Okay, good. It's our friend right here, running right along the top. See this? Okay, this is the cord structures running here. And I'm going to sweep this over the tubercle and then isolate the cord. And okay, you can hold like that. Okay, good. So this is always the issue with cadaver, is that the tissue is kind of fused, but that's okay here. So we're going to sweep under, and on this side, we're going to sweep around, and the cord structures will come up like this. Okay, good. All right, so here's my cord structures coming up and over here. So we're going to have to see if we could free that here. Not the greatest of specimens here. It's this way here. See if I could show that better to you guys. Okay, good. So what you're looking for here in this anterior canal is this, your cord. This is fused here. This is tubercle here, and this is the cord right here.
Head.
Very aggressive, Leandro.
Oh, we can see
Alright.
that you're struggling with the dissection.
Yeah, it's really kind of dense here. Okay, and here actually it's because this is quite medial here. Okay, here, I'm gonna open it wider, then you guys can see it. That'll make it easier. Okay, good. Look over this way. Okay, so if you can hold, this will help them to see it. Okay, so if you can hold like this, okay. It's a little bit distorted anatomy because of the cadaver and insufflation. Okay, so here now is going to be my cord right here. Coming out here, and we'll get around it here. Let's see. Here's cord structures, and normally, obviously, I would try to not traumatize this, but here's the cord here. And we're going to get around that. So So I try not to ever take my fingers and do that, but just harder in a cadaver where it's all frozen together. Okay, so here's your cord structures. Okay, so on the medial side now, okay, now you should be able to see that a little easier. So she's actually holding down conjoined tendon there. Okay, so we saw here, this here, and this here.
If you
Okay,
can,
this
if you
is
can put just your head a little bit to the right. Yeah, right now it's perfect. If you
Okay,
can do this,
good.
it's perfect right now.
So this is here conjoined tendon, okay? So what you have here is the internal oblique muscle, which you see here, the external oblique muscle here. You see the nerves exiting at the meeting. So this is iliohypogastric nerve right here. You can make it out right there. It's actually two branches. There's this one here and this one here, exiting out the conjoined tendon. This is the aponeurosis of the internal oblique. Right behind that is the rectus muscle. That's so if you're doing a relaxing incision, let's move this one out here. If you're doing like a relaxing incision in a Bassini or a McVeigh, it's right here. So now here's the floor of the canal. This is Hazelbeck's where you get a direct hernia. Okay, hold this guy here. And now we'll see if I could show it to you a little better now. Okay, there we go. Okay, we saw ilioinguinal nerve passing right over it before. There we go. Okay, here's your cord. Okay. Ilioinguinal nerve is right on top, the very top running on top of the cord, this guy here. Genital nerve is here. When you look at the lateral side, you'll see the blue line of the external spermatic vein. You hold this taut. Okay, and you'll see then, let me point it out. So if this is the blue line of the external spermatic vein here, this is the white line of the genital nerve. Now, you don't need to actually find it or isolate it in real life. You need to actually keep it in the cremaster. So these cremasteric fibers, when we open them longitudinally like that. And so when we're looking for an indirect sac, we dissect the cremaster longitudinally until you find the vas deferens. And when you find the vas deferens, which is right here, okay, this is the vas, you say, how do I know if there's an indirect hernia? If you find the vas at the level of the internal ring, and there's no sac right on top of it, there is no indirect hernia because the anterior wall of the vas always meets the posterior wall of the sac. So again, like here, this is the external spermatic vein, the genital nerve, the ilioinguinal running right on top, the iliohypogastric running to the conjoined tendon right over here. Now, here's finally the spaces, and then we'll switch over to yours because we're just showing neuroanatomy in this one. So this here, if this is my cord here, okay, if you could hold like that. If this is my cord up here, then the epigastrics are running like this, right? Hazelbeck's triangle is made of this here, inferior epigastrics, this here, the rectus, and this here, the inguinal ligament. So the floor of the inguinal canal is here in Hazelbeck's, okay? So if I had an indirect hernia, I look in the cord. If I have a direct hernia, I look on the floor. So this patient does not have a direct hernia, but I'm going to open the floor now, right? And so here, this is transversalis fascia. And you see there it's open now, right? And so here, when we open up the floor here, we enter into the preperitoneal space. And I've done this dissection already. So what we can do is then access this. And this is why people love plugs, because you say, oh, that looks really good, right? So pushes it down, makes you feel good about yourself, but then the patients don't like it later on. Okay, so but let's show you then this anatomy, and then we'll be finished with this. So this is the direct space. I'm gonna put another plug in there, and then I'm gonna hit the third plug, and we're gonna say, okay, we'll call it a day. So now here's your cord structures. Here you can see right here is your inferior epigastric artery and vein running right here. That's the artery, that's the vein. This is Hazelbeck's triangle in here. Here, right here, you can see is Cooper's ligament, right here. This is the iliopubic tract, or on the top side, inguinal ligament, iliopubic tract, which is the back side of it. Cooper's ligament, you get the light right in there? Cooper's ligament here, the iliac artery and vein right here, you can see, and this is your femoral canal right here. So I feel right here, does the patient have a femoral hernia? No. But if they did, I need to do something to cover this, either a McVeigh that sews this down to the Cooper's ligament, or, you know, people put mesh in here, or a triangular extension on a Lichtenstein, or ideally, you do a preperitoneal TEP or a TAP. The final thing I'll show you is that when you're doing a shoulder ice repair, is that this here, we said this was conjoined tendon, right? So this is aponeurosis of the internal oblique. This was the muscular portion where you get hernias. And then this here is this arch, this ligament of Henle. And so here on the back side, when I pull on this, is the lateral aspect of the rectus. And so this is the ligament of Henle. And so this robust structure, when you're doing a shoulder ice repair, needs to be brought over to the to the inguinal ligament. And so it's the first layer goes, not this stuff here, but the ligament of Henle
Your
back
head
here.
a little bit to the right, David. A little bit.
Right?
A little bit, your head a little bit. Yeah, perfect. Perfect.
Yeah.
Sorry about that.
Here. Okay. So there, if you hold like that, she's holding the internal oblique muscle. See this? Let me grab it here and you'll be able to see it. So this is the ligament of Henle right here. This very pronounced structure right there. See that? That's the lateral border of the rectus. And so when she relaxes a little bit, see how this can be swung over to the inguinal ligament? That's what makes a shoulder ice work. You're bringing the rectus, here's the rectus, and instead of the rectus coming like this, you're broadening the rectus to the inguinal ligament, covering this weak space. And that's what you need to understand. So a shoulder ice does that in 4 layers. 1 layer with the ligament of Henle, 2nd layer with internal oblique, 3rd layer with internal oblique, 4th layer with internal oblique. Bassini, alternatively, takes the triple layer, which means that you take a bite back here, where you get aponeurosis, you get muscular, you get rectus, and you get this ligament of Henle and the transversalis fascia. And it's basically the triple layer, 1, 2, 3, 4, 5, all the way to the inguinal ligament as a tension-based repair. And that's why typically it's described here with a relaxing incision. And you'll see what happens when I cut here and relax it. See how it shifted over? The whole thing just moved over. And so that's what makes it broaden with the Bassini and McVeigh. Okay, so that's enough anatomy for this. And Yuri's going to jump over to TAR now. Any questions?
Awesome.
No, it was so perfect
was
that
great.
nobody has questions. Thank you, David,
Thank you,
for
thank you.
Okay, let me deconstruct this for you. Yeah,
All right.
thank
We're
you.
going to switch over to Yuri for retromuscular and TAR dissection.
Just attach it here. And just put it in a pocket again. Yeah. Thank you. Can you guys hear me now?
yeah,
Yes.
you're live.
Excellent. That might get this. All right. All right. I have blood supply cut off where they go from. It's all right. I'm good. It's fine. Let's. What are we seeing?
We see,
We have both images,
Yeah,
one
both
from your head and the other one from the room. So both are focusing on the cadaver.
Yeah, but we were gonna turn the cadaver, right? So I'm doing the right side.
Yeah, we have both images,
oh,
Yuri.
so
want me to
then,
come
so
from there.
then you're going to
So
switch.
shouldn't we turn the cadaver so it comes this way?
Yes. Yes.
Okay, let's do that.
Yeah,
Yeah,
yeah.
I'll just stay outside of this. All right, so guys, all right, so this is head, this is toes.
Perfect.
I can, all right, you'll tell me if they can see. All right, so the initial topography and Roger went through this really nicely. It's the same thing. So we're gonna essentially end up in the same plane. I can cheat a little bit because she already started and finished the space of dissection and up top here, subtype point. So there's 3 ways to start. We don't have a Bowie. I'll use some sort of this scissors. There's 3 ways to start. So one is just you figure out where the edge of the rectus muscle is, and you make that incision in the posterior rectus fascia. If you make it too lateral, you're sacrificing posterior fascia when you didn't have to. If you make it too close to the edge, sometimes you could be past the medial edge of the rectus and doing a dissection in subQ plane. All right, so that's start number 1. I'm gonna So I'm gonna just do reef stopper here. Missing few surgical tools, but it's all right. So this was arcuate line contribution to linear alba, which I just divided. So so this is our retrorectus dissection. Notice there's a tissue here. That's transversalis fascia. I want to say I want to leave the transversalis fascia up, typically in the lower abdomen. But anyway, so I'm going to complete my reef stopper here. So as we go with the reef stopper, we're just gonna take it down. And sometimes I will not take the entirety of posterior rectus sheath. This is the falciform. So I'm gonna sort of, depending on the hernia, you obviously don't always have to go, but here, let's assume I'm gonna go all the way high and take it down. So this is the falciform ligament. Hopefully I'm not gonna cut myself. Let's see. Use HS in short. All right. So what do we have here? We have retrorectus dissection. And so this is what Grandpa's Reeves and Stopa gifted us. See, that's flim flim. So there's a name to this fashion. I always forget. So I like to stay not as close. As you
Can
get
you
closer
guys
to
zoom a
arcuate
little
line,
bit the camera from the room?
camera from the room from there. Yes, let's zoom it in.
Yeah. Yeah.
Okay, so
Nice.
what do we have here so far? We're having a retrorectus dissection. The lateral aspect of this dissection is it's the perforators and it's semilunar line. And you can see here, this is gonna be great. So I am perforator, perforator, perforator here. You have lights come from my left shoulder. I'm gonna exaggerate here a little bit. Perforator, perforator, this is our TA, it's showing already. So. All right, perfect. All right. So now we've completed posterior rectus sheath release. And what's interesting about this stuff to me is that we're discovering that posterior rectus fascia is not very elastic. So as you can see, the reason reef stopper works for medialization of the rectus muscle, because now rectus muscle can be stretched. So it goes from being kind of ovoid shaped to more flat. You see, it used to be here, and now I can really stretch it. So the muscle kind of, that's the nature of this myofascial release. It just elongates the muscle. So interestingly, even if you can restore anterior rectus linea alba, you may have excessive tension on the posterior layer. So that's one of the limitations, and that's partially why sometimes we need to do something else, either develop reperitoneal planes, or if you're already in the retrorectus space, you kind of see your only other option is to for posterior fascia is to do the TA release. Okay, so now it's the time to do the TAR. So again, that just started me off already here with the her dissection. Okay, so David was just showing we kind of all end up in the same plane. This is, so I'm just gonna cut this because I can't see. All right. So to start the TAR, sorry. This is, I can start from the bottoms up. I can start in the middle, or I can start from the top. All right. So if I wanted to start from the bottoms up, I need to find the arcuate line. And I think it was already done. So I'm just going to excise the arcuate line. Once you excise the arcuate line, if you look here, you'll find yourself in that retroperitoneal plane that David was just showing us in the inguinal canal. And that's that retroperitoneal cape. So if I'm going from the bottom up, I'm going to incise the arcuate line and find myself in that lateral retroperitoneum and go cephalate. If you look here, Sarah, hold this. So I'm already almost halfway through by just the virtue of that initial incision, but I'm in the same dissection that was just shown. It's a pure preperitoneal dissection. But we're taking the posterior rectus sheath. So I don't want to go the whole way. The dangers here, and I always say, is to get disoriented and cut what is a similar line. I'm going to cut the similar line on purpose. Lift up a little bit. Let me put it like this just to show. So as I'm coming, yeah, just take a big break. As I'm coming here, pretend like you got disoriented and you went, instead of staying in this lane, I'm cutting the similar line. So I just got disoriented. So because you can see right here, we're very thin, sometimes all the way through. So you have to be careful not to do that. I'm gonna stop this just for the purpose of this dissection and now show the upper entry point. So there's a few potential ways to start the top on the top. One is we clearly found the perforators. We found everything. So now it's the question of just, see, the muscle is obvious, right? So we can just cut here. The other thing that I like to do, and it's very important to remember, it's not a vertical release. It aims toward the xiphoid process. It really kind of makes this curve here. So sometimes, tell fellas, it's like creating an upper arcuate line. You leave a little bit of a posterior sheath behind. This is similar to what Miguel Orena says as a Madrid modification. So, but now, once I'm here, I'm going to make a turn, not like that. This is actually pretty thin. Yeah, I don't have enough instruments. Yeah, I'm just cutting, so it's not the safest way. Anyway, so you can see I made a hole. It's not a big deal. So what separates sometimes is to recognize that you made a hole and not to propagate it anymore. The problem is we don't have a right angle and a Bowie here. So what I just did, I went below the rib. So I made this incision and I made below the rib, put it here. So the rib is now right here. And now I'm on the diaphragm immediately. So sometimes I put my finger and I dissect along the costal margin. And all I'm doing is just following the preternalis plane along the costal margin. I'm going to show you that with this visualization, David, if you could lift it up. I was already here. So if you think about what I did before from the bottom, my fingers essentially touch. So there's actually, if you're in this right planes, you can very quickly dissect into the retroperitoneum. Okay. So then, see, I made this hole. So when you make a hole, this thing you need to do the most is go away from it and then work lateral and around it. Yes, I wish I had A light and B right angle. Every time I do this, I keep reminding myself, am I careful enough not to go too lateral? The perforator's here. I'm gonna, for the sake of a mistake, I'm gonna shine light here. See, if you're using rectus muscle as your guide, you're wrong. Because you can be seeing anterior rectus fascia beyond the lateral aspects of the rectus. And when you pull it hard, like, for example, right here. Can you guys see this little spot?
Yep.
Yep.
Right. So look at this. This is the perforator. This is posterior rectus fascia. This is anterior rectus fascia. If I were to make the hole right here, that's a similar line injury. See, David is on the other side. Do not use rectus muscle as your guide. You have to stay, because as I overextend, I take what's anterior rectus fascia and it becomes my ceiling. So what it means is continue to respect the perforators. And so now, hold on, just give me a little time to recover. So I'm now respecting the perforators. I'm just cutting the muscle. Again, like, we're gonna make little holes because I don't have the Bowie. I don't want to cut my finger.
This one.
Yeah. But now that I identified the muscle and identified, are you giving me a retraction through the similar lines? That's great. That's great.
Mickey Mouse technique.
Yeah, exactly. Not approved by the FDA.
California
Yeah, yeah. I'm actually, so let me just, for the purpose of, so she is very thin here. And no matter what I do, it rips. So if that were to happen, I would go further, more lateral. And I would identify with the similarities, and I'm gonna cut these planes. So it got hard for in the middle here. So I went around it. So at every point, I'm respecting, uh, again, my identification of semilunar line, and I'm respecting my visualization of the retroperitoneum. Hard to do about it. So notice here, that's not what I want to see, because this is transversalis fascia, right? So what ideally I want to see is naked red muscle. And be in that plane. So if you get in the wrong plane and see the TA is coming down, every time I do this, the TA is just coming down. You're doing everything blunt, it just doesn't always work. I need to lift it up. Are you still digging through?
Hola.
Yeah, Yuri, there's a question from the audience.
Yeah,
Go ahead.
Hello,
yes.
Professor. Raul Rodriguez from El Salvador. What's the distance that you use to do the cut in the subxiphoid area?
So I don't measure it. I just, when I see the muscle, I just start aiming towards xiphoid. So I would say maybe 4 or 5 centimeters. I want to, because the diaphragm comes over and inserts into posterior sheath. So you don't want to be right on the rib here. You want to be keeping, and if you see any muscle down here, that's the diaphragm, so you pull it up. So the other thing to demonstrate, again, in this cadaver, I made a couple of holes. But what's important is, by the time you're done, you just close your holes in the lateral to medial direction, right? So the more I pull, this continues to rip. So I would just take this and I would close it in the. All right, this doesn't. I want some instrument that will grab it. Let me see what else. So I would make it like this, and I would close that hole no matter how big. I would convert it from a round to oval and just close it towards me. We've already dissected the other side, but normally I would see we're in a couple of different planes here. Then I would go in there, staying below the diaphragm and dissecting all the way down. And if we had a Richardson. To get to the central tenon of that. Yeah, this cadaver is a little bit thin. Yeah. 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 So as long as there's no muscle on the floor, you're not hurting the diaphragm. All right. And then I would go back down and connect the dots. So in open surgery, I would do the whole side. I would leave 12 and 6 untouched. I would do this side, and then I would connect the dots. And then you go back and recheck. And again, at this point here, I had cut the semilunar line. It's not the end of the world if you fix it. So you just go back and recognize where's our hole there. So somewhere here, we had made a hole. Just go ahead and fix it. Just use permanent stitcher, puts a couple of stitches. Remember, the mesh is gonna go very lateral, and you're gonna be done. All right.
Yuri, what would be the lateral limit of the dissection? How far you would go laterally?
So I want this tissue to be lying on the viscera and not hanging off the floor. The way
Okay.
the tower works, just like what Vedra was showing with anterior component separation, is you want it to be completely disconnected. This is close to the rib. If the tissue is still attached here, it's not gonna advance. If you completely detach it, that's the release. You have to completely remove the contribution of the transverse abdominis. When it's like that, even though I did TA, I cut the TA, I dissected. If this is still engaged, that's all, you're not gonna be able to release the entirety. So what I say, you're gonna go all the way lateral, so the posterior elements are just lying on the viscera and not hanging off the ceiling. That just completes the dissection. And now it's much freer. The idea is it's a component separation. Cutting anything is insufficient unless you completely deactivate it, right? Each muscle plays a role. External plays a role, internal plays a role, and transversus plays a role. All those three muscles keep the rectus from being medialized in the setting of a hernia. So by cutting whatever one you decide to cut, you're loosening up the lateral tone and the muscle advances. So that's the idea. And it's different from the principle of what Reeve Stopa does, because what Reeve Stopa does is it changes the shape of the rectus muscle. It goes from ovoid to more flat, and that's the advancement. Essentially, when you finish the Reeve Stopa, your linea semilunaris only moves because you're pulling. When you do a TAR, linea semilunaris is now less attached, so it's medialized by both pulling the rectus muscle, but also by reducing the tone of the lateral musculature. Okay. That's
Yuri,
like a
one
C
more
plus
quick
dissection.
question is, in an era of endoscopic reeve
The best I
stopas
got.
and robotic reeve stopas, there have been episodes where we see limited tar, people who just make some incision and release it. What's your opinion on limited tar?
Say it again.
We have seen robotic surgeries and endoscopic reeve stopas where they would just do a limited tar to get
Yeah.
a midline approximation. So your views on limited tar?
Yeah. Well, it's like a little bit pregnant. I think that's a limited tar. It's like cutting the muscle. That's what you do. You just cut the muscle. So I don't like when people call it limited tar. It's just, that it's just the posterior lamellar release, partial division of transverse abdominis muscle. You can do those things. All those maneuvers will give you some benefit. So, and whatever is needed. So you can achieve, sometimes I'll do a really large subxiphoid hernia. Reeve Stopa is plenty, but in the upper abdomen, I just want to cut a little bit TA to make myself better room there. It's not really done for that much medialization, just for space. So you'll cut the top, 2 centimeters, 3 centimeters of the muscle. I don't call it tar. I don't build like this. I don't name it. I just cut a few muscle fibers, and that's important. These notions of partial tar, again, it's
Okay.
I think we have one
Like Ray
final
Charles.
question from the audience before we.
Yuri, yeah. Can you just show us from there, how would you do a reverse tar?
reverse tar. Exactly. There's a course for sale. No, reverse tar is the idea comes from for flank hernias. It's not for midline hernias, meaning you start in the preperitoneal plane, preterinalis plane, and then you move medial. And at some point, you can't stay preperitoneal because it thins out. It's hard to dissect and stay. If you can stay preperitoneal, you don't need to do reverse tar because it's not done for any myofascial benefits. But if you are transitioning and at some point the peritoneum is thinning out and you need to jump retrorectus, so you cut the TA that's on your ceiling of your dissection and then you jump in the retrorectus plane. It's for flank hernias that are purely flanked. These days, I do less of that because with the robotic surgery, we'll do a lot of that dissection robotically, almost like ETAP style or TA, and then if I needed to add the hybrid dissection through the open incision, I'll do that. So with the advent of robotic surgery, I almost don't do this reverse tars anymore because it's not reverse. I do it forward robotically and finish my preperitoneal dissection. And importantly, layered fascial reconstruction open with taking a very good anterior repair with good bites of external oblique and so forth. So anyways, but the principle is the same. You just go from retrorectus to preperitoneal or from preperitoneal to retrorectus.
We have a final question from a young surgeon in the audience, Yuri.
Hey Yuri, can you just tell us how what CPT codes you use to charge for an open TAR bilateral?
Well, it depends. As you know, we're working on this. So oftentimes I'll do 15734 times 4. If I feel every release was justified, sometimes I'll do 15734 and 14301 for if I did the second portion of operation to create space. It's still debated, and it's as you know, we're gonna have a coding bulletin coming out on behalf of AHS and hopefully soon, and all those issues are going to be addressed. It's really hard to what goes into consideration of how you build is what do you actually do and why you do it, and you have to truly. We don't have a code for talk, so we have to justify the need for each step, for each release, what's done, why it's done, and what's the benefit, what's the effect. And if you have, so if you describe these things and they fit the CPT code, then you use it. If what you're telling is not really fitting the CPT code, then you shouldn't use it. Does that make sense?
Yeah.
Yep.
All right,
right.
well, I want to thank you, Yuri, David, Vedra, and
Our
Jignesh for your
assistant.
guys's, what? And your
And our
assistant?
assistant, yes.
Yes, everybody there at the lab. This was really a great session. Thanks to all of you for
Thank you.
staying over, and we'll see you guys at the welcome reception down in the exhibit hall.
All right.
Thanks, very nice.
Maybe like B minus at best.
Vedra, get in there. And then let's get the residents in. Okay.
Yeah, let's go.
Vedra, get in.
I look like I'm exploring.
Yeah. Spelunking. Are you?
No, no.
Now I can't take it.
I don't want to, wait, I can't.